Good morning. There won't be any more better attendance at 9:10, so we might as well start now. The first talk is from Singapore, Ravindran Kaneeswaran. So this is the topic is going to be of adjuvant treatment and selection of the drugs in various conditions. So we'll start off with the renal cell carcinoma. We have got the downloaded video, so we'll play that. Is Sunirmal Chowdhury or Suman Malik here? Yes, sir. I know Jagdish Kulkarni sir is not here. You are a medical oncologist, radiation oncologist. Yes, Jagdish sir is not there, and Suman Malik is. You are Suman Malik, so Sunirmal Chowdhury is not there yet. Okay, I'll give you company. Jagdish sir. Jagdish sir, I was keeping the seat warm for you.
Hi, my name is Ravi Kaneeswaran. I'm a medical oncologist at the National Cancer Centre, Singapore. I'm also a member of the ESMO RCC Guidelines Committee. I'm very grateful to the organizers of SOGOCON 2024 for this very kind invitation. I'm really sorry I can't be there with you in person, but I'm still honored to be able to share with you on this topic of patient and drug selection for adjuvant treatment in renal cell carcinoma. These are my disclosures. In the outline of my talk today, I'll talk about an introduction to this topic and why we need adjuvant immunotherapy or adjuvant therapy in RCC in the first place. And then I'll deep dive into some of the critical data, especially more recent data that have shown overall survival benefit for the role of immunotherapy before I summarize. In my practice in the National Cancer Centre, Singapore, I do predominantly a GU oncology practice. So I see kidney, bladder, and so on. I see roughly about 5 to 6 new metastatic cases and roughly about the same number of adjuvant cases. And this has increased over the past year because of the data that I'm going to present to you. We are fortunate we have a healthcare system that reimburses for most of these treatments. And I'm also actively involved in research. We are part of the IMDC and many similar consortiums globally. We also run clinical trials, and that's where we hope to be able to, bring breakthrough treatment to our patients. Now, why do we need adjuvant therapy in RCC or localized RCC? If you look at some of the data, this dating back to even, 5 to 10 years ago, clearly there is a risk of relapse in these patients. And this includes patients who have intermediate high risk, not just the high risk patients. So, and later I'll show you how we classify patients into intermediate high risk, and a new category called M1-NED. Now, about between 40 to 72% of these patients, depending on their risk status, actually have recurrences within 5 years. That's a very high number. So we obviously need to do something to reduce this risk of relapse, because we know once they relapse, it becomes stage 4 and a terminal disease in most circumstances. Now, if you look at time to recurrence post-nephrectomy, that's also much shorter depending on how aggressive the disease is. On the right-hand side, the Kaplan-Meier curves, you can see if they have a T3 grade 4 disease, they relapse much faster compared to those who have T3 grade 1 or 2. So with that in mind, the number of adjuvant therapies have been designed over the past decade. However, initially it was all based on TKIs. That has been the standard of care in the metastatic setting for many years. Of course, now that has changed with combination therapies of IO plus TKI. So they looked at sunitinib, sorafenib, axitinib, and even an mTOR inhibitor, everolimus. Now, all these studies, except for the extract study, which was published in the New England Journal in 2016, were all negative for disease-free survival. The only one that was positive for the sunitinib study, nevertheless, it did not really reach mainstream practice because of its toxicities. And I'll show you why in a short while. The last of these studies was presented last year, and the Everest study with the mTOR inhibitor, unfortunately, that did not meet statistical significance. Hence, we really didn't have any good treatment in the space. Now, why wasn't sunitinib used? One of the main reasons for that is sunitinib is very toxic. And we know this is more so in the Asian population. Most of our patients cannot tolerate 50 milligrams, 4 weeks on, 2 weeks off. Although now many have switched to the 2 weeks on, 1 week off regimen, it's still very challenging because many of our patients have grade 3, 4 AEs. And if you look at the EORTC QLQ-C30, a very important QOL, quality of life tool, and for the specific global health status domain, clearly there was a decline when patients used sunitinib. So yes, it had disease-free survival benefit, but no OS benefit and severe toxicities causing detriment in quality of life. Hence the rationale for immunotherapy, right? Immunotherapy came in the metastatic setting about 8 years ago, and there was a rationale to then develop this in the adjuvant setting. And clearly there was benefit seen in other tumor types, like melanoma, for example. So with that in mind, 5 different trials were designed using different immunotherapy regimens, right? The first 4 have been reported, only left with Rampart, which uses an IO-IO combination, durva-tremi versus durva versus observation, while the rest were all PD-1 or PD-L1 inhibitors. There's one Checkmate 904, which used Ipi-Nivo, also an IO-IO combination. Now, these trials were very different. If you look at, individual trials, some were given for a year, some were given for just 6 months, like Checkmate 914, and one trial actually had a neoadjuvant or perioperative approach, and that's the Prosper RCC trial. Here you can see patients were given neoadjuvant nivolumab for 2 cycles, then had surgery, and then adjuvant therapy every 4 weeks for 6 or 9 months of treatment. Now, the endpoint for all of these were both disease-free survival, those were primary endpoints, and overall survival for some of them as secondary endpoints. So let's just deep dive and see how these trials fared. Okay, but let's start with the first one, Keynote 564. This is probably the one all of you are familiar with, and that is because patients in this study benefited from the use of pembrolizumab. Now, patients in this study must have had, high risk of relapse. So they were either high risk, intermediate high, or M1 NED. In a short while, I'll show you what those definitions mean. And they were then randomized to receive 1 year of pembrolizumab or put on placebo IV. And the primary endpoints, as mentioned, was disease-free survival. This was met in the earlier outcomes that were published a couple of years ago. And other key secondary endpoints, including overall survival, safety, quality of life, and event-free survival. These were the pre-specified categories. So to be classified as intermediate high risk, you either had a PT2 tumor with grade 4 or worse grading, or PT3 any grade, then you'd be intermediate high risk. Bulk of the patients were in this category. There were also high risk patients, which is PT4 any grade, or any PT plus involvement of lymph nodes. And M1 NED, this was a minority of patients. Roughly about 6% of the patients enrolled in this trial were M1 NED, meaning to say they had a nephrectomy, they had an oligometastatic site which was resected within a year of the nephrectomy, within 12 months of the nephrectomy. Then they were classified as M1 NED and given opportunity to enroll in this trial. Now, it met its primary endpoint, as you can see here, DFS benefit met with a hazard ratio of 0.68. 6 months later, in the 30-month follow-up, it was 0.63, clearly showing benefit. However, at that point in time, there was no OS benefit yet. Now, what about toxicities? Quite typical of what we know of immunotherapy. So patients have fatigue, pruritus, hypothyroidism, diarrhea, and rash as the 5 most common toxicities. If you look at grade 3, 4 toxicities, not very toxic, actually. Now, let's look at the immune-mediated AEs. Before that, let's talk about treatment discontinuation. Now, of course, patients on the pembro arm had more treatment discontinuation rates, roughly about 20%. However, very few of those events were causing death or even very serious AEs. Now, when we look at immune-mediated AEs, the most common were things like hyperthyroidism and hypothyroidism. So definitely this is something quite typical of what we see in our patients as well. But when you look at grade 3, 4 AEs, they were all roughly about 1% at best. So this means patients did not suffer from very severe side effects. Now, what about the Asian population? So when you look at subgroup analysis of Keynote 564 in Asians, and most of these were in the East Asian population because that's where the clinical trial sites were open, the hazard ratio is 0.52. Looks a bit better than actually what was seen in the Caucasian population. And that gives us some confidence that this is going to work in Asian patients as well. Now, when we look at the data for all 4 studies that were reported thus far, only Keynote 564 had disease-free survival benefit. Now, Checkmate 914, again, used only for 6 months. There was no DFS benefit. Emotion 10, using Atezo for 1 year, no DFS benefit. And Prosper, the interesting perioperative approach, no relapse-free survival benefit. So it one trial with a disease-free survival benefit, which was reported 2 years ago. Now, was that enough to change practice? I think people were a bit skeptical. Why was this trial positive? Maybe we should wait for overall survival benefit. So if you look at guidelines, while they recommended a discussion, especially for those with high risk or M1 NED, it didn't mandate the use of this therapy at that point because there was no OS benefit yet, and there were 3 negative trials. But why were there 3 negative trials? What were the differences? There were different trial designs, as I showed you. In one neoadjuvant study on top of that, so completely different approach. Durations were different. The type of immune checkpoint inhibitors were different as well, and we have seen this in lung cancer and many other tumor types, where even amongst the PD-1 inhibitors, some may be positive, some may be negative. Maybe there were different populations biologically. That was true. However, maybe the best way forward, and I think we're going to see more and more of these data coming out. We see it in bladder cancer already in a post hoc analysis of the IMvigor 010 trial, where patients who had ctDNA positivity actually did worse compared to those who had negative. That's from a prognostic perspective. From a predictive perspective, those who were ctDNA positive who had immunotherapy did better than those who did not have immunotherapy. So maybe we should focus our immunotherapy on patients who have minimal residual disease, MRD, and that's a big space that is being investigated. And this was a study run by Dr. Tom Powles, and he is now running the IMvigor 11 trial, looking specifically at this in a randomized control manner. Now, what has changed was this year, Tony Chiuri and team presented Keynote 564 OS data, and it met its primary endpoint, hazard ratio 0.62, which means it's a 38% improvement in overall survival for patients who receive 1 year of pembrolizumab. Now, this has changed practice. Now, patients should be referred by urologists to oncologists for this discussion. Nevertheless, as usual, there will be some critique of, the data. Firstly, as you can see, at the 48-month mark, the absolute difference in OS is 5%. Now, is that something meaningful? That's something that only you can answer and something your patients can talk to you about, right? So this is something you need to explore with them, explain that, yes, there's OS benefit, but it's about 5% at the 4-year mark. Now, the other thing was, what subsequent therapies did these patients get? Now, in many trials, if in the subsequent therapies and in the advanced setting, we're talking about second line and beyond, most patients get the therapy that was tested up front, then it may show benefit for giving these therapies up front. Now, the reality is, in the placebo arm, and let's focus on what subsequent therapy they have. Firstly, number one, 20% did not get any subsequent therapy. Now, the balance 80%, right, you need to deduct about 50% for those who receive radiation and surgery down there. And amongst those who receive systemic therapy, which is half of that, right, about 80% receive about 70% receive anti-PD-1 therapy, meaning to say not many patients receive subsequent immunotherapy. So it is hard to then conclude that, the benefit is really because of upfront versus late immunotherapy. So with that in mind, we had discussed this as part of our ESMO clinical practice guidelines. And in that, we just published this not too long ago. We did recommend that these patients who had radical nephrectomy, whether it's T1, T2, or T3, T4, depending on what were the findings, right, should be considered for adjuvant pembrolizumab after surgery. And this is a 1A recommendation with MCBS A, meaning this has been shown to be, assessed for its value as well, meaning they take into account not just efficacy, but also toxicity. So in summary, Keynote 564 is the only study so far to show OS benefit in the adjuvant setting in RCC. So historically, this is a big moment because we do have data in the space right now. Because we wait for RAMPART to see whether there's more, support for this data, especially with the IO-IO combination. In terms of AEs, it's quite consistent with what we know. But what's crucial here, I think, is MDTs. We should be having more MDTs. Surgeons should discuss these cases with their oncology colleagues, especially when there may be oligometastasis and how to deal with them and what to give them after that. We want to reduce relapse, and that's critical in order to get the best survival for our patients. With that, I want to thank you very much for this opportunity, and I hope you have a wonderful meeting ahead.
Any question?
He's not live on. We need to ask some other medical oncologist.
Okay.
Yeah, that was just a recorded video.
Okay. All right.
So we can move on to the next talk, sir. Adjuvant versus early salvage RT for prostate cancer. Who benefits from adjuvant treatment? Moses Arun Singh.
Morning, everyone. Well, there have been many trials which has looked at whether there is any role for adjuvant radiotherapy in prostate cancer, and there still seems to be some controversy on whether some patients will benefit from adjuvant radiotherapy, and that is what we are going to look at over the next 10 minutes. So what is the usual protocol when a patient undergoes radical prostatectomy? So this is what we get after a patient undergoes prostatectomy. You get a histopathology report, and you also do a post-operative PSA at around 4 to 8 weeks. If there are no adverse features and the PSA is undetectable, you just keep them on follow-up. If the PSA is detectable at that time, you offer them salvage radiotherapy. And if there are adverse pathological features which point to a higher risk for recurrence without the PSA being detectable at this point, you can either offer adjuvant radiotherapy or argue for salvage radiotherapy. So this has been the bone of contention for a long period of time, and I'm just going to take you to the history of how things have evolved in this area. What are some of the adverse pathological features that we consider as being at high risk for recurrences? So we know for a fact that T stage definitely plays a part. The higher the T stages, the chances of local recurrences and distant recurrences in addition to biochemical relapse is higher. You look at positive margins, not just a single positive margin. If you have multiple areas where there are positive margins, they are at a higher risk for recurrences. And also Gleason score, more specifically the Gleason scores at the margins are associated with worse survival. This is apart from the traditional more robust risk factors like node positive disease and the presence of detectable PSA in the post-op setting. But what exactly do we mean by adjuvant radiotherapy and salvage radiotherapy? Adjuvant radiotherapy is when you deliver it regardless of the risk for recurrence based on the pathological features that you see. And salvage radiotherapy is when you don't have evidence of distant metastasis, and you offer radiotherapy on the basis of PSA recurrence after surgery. And you can classify this into upfront salvage, where you have detectable PSA at the post-op setting, or when you have missed the boat to offer early salvage and the PSA has crossed the limit, at which point you would offer early salvage, which is between 0.1 to 0.2 in the post-op setting in the current era. So this is where many trials have been done in the past as well. So these are very old trials. We've all debated over this many times. So adjuvant radiotherapy versus just surveillance alone. 4 large trials. All of them seem to suggest that there's a definite biochemical benefit by offering adjuvant radiotherapy for patients who have undergone prostatectomy. And this was definitely seen in the meta-analysis as well of these 3 trials, which showed that the 10-year freedom from ADT-free treatment duration and also biochemical failure, all of these were improved by offering adjuvant radiotherapy. But the criticisms were that only one of these trials ended up showing an improvement with metastasis in terms of metastasis-free survivals and overall survival, which are more clinically meaningful endpoints. And a more updated meta-analysis, including all the 4 trials that I had shown before, did not really show benefit in terms of all these endpoints as well. Some of the other criticisms were that not all of these trials actually mandated undetectable PSA at the time of inclusion in these trials. And when the patients did receive salvage radiotherapy, the salvage radiotherapy was typically ADT alone. Not many of them received salvage radiotherapy, and even if it was incorporated at a time where the PSA level had risen quite high and would not be considered appropriate to incorporate salvage radiation at this point of time. So going by the way the PSA was recurring in the observation arm, it seemed that a significant proportion of patients would get overtreated by offering adjuvant radiotherapy across the board. And with the availability of highly sensitive PSA, early surgery, early salvage was looking like possible, and possibly reducing the side effects as well. And that set the stage for more modern trials where we looked at offering adjuvant radiotherapy versus early salvage radiotherapy. Raves, Radicals, and GETOG, all of them showed that at least the 5-year biochemical progression-free survival was equivalent by offering early salvage radiotherapy as opposed to offering adjuvant radiotherapy for all, with the benefit of sparing late urinary toxicities for these patients. But some of the cautions that were warned were that these were all only still biochemical progression survival that we were reporting, and a lot of high-risk patients were not really included in these trials. Even the meta-analysis, because they pooled the data from all these 3 trials, may not be actually powered to identify a benefit for adjuvant radiotherapy in this high-risk group of patients. But when we look at proper propensity score matched studies for this particular group of patients, it seems to suggest that adjuvant radiotherapy may actually improve all-cause mortality by as opposed to early salvage radiotherapy. But what do the guidelines recommend? The ASTRO-AAO guidelines definitely has taken the cue from these more modern trials and suggests that we should not be routinely offering adjuvant radiotherapy after radical prostatectomy, but patients at highest risk of recurrence were probably not properly represented in these trials, and we should have a discussion with patients for these for offering adjuvant radiotherapy as opposed to early salvage radiotherapy. And for node positive patients, again, you should consider other risk factors like the presence of and the number of nodes, and also whether the PSA is detectable or undetectable before deciding on whether you are going to offer adjuvant radiotherapy. The EAU guidelines as well echoes the same sentiments and more or less go on the same line. But my contention is if PSA is considered as a valid assay for detecting recurrence for the so-called low-risk adverse features, why can't it be considered the same for high-risk adverse features as well? And I feel it is the threshold at which the RT is initiated is what matters, and lower the threshold, the better the outcomes are. So what do we do at our center? We offer immediate salvage radiotherapy for anyone who's got detectable postoperative PSA, and for anyone who's got pathological node positive disease, regardless of the number of nodes or the PSA levels at that point of time, we offer immediate adjuvant ADT and also adjuvant radiotherapy along with pelvic nodal radiotherapy. We follow early salvage radiotherapy across the board. If the PSA crosses 0.1 after being undetectable at the postoperative setting, we offer them salvage radiotherapy before it crosses 0.2, and if the pre-RT PSA has already crossed 0.3, then we also offer them a short term of ADT as well. With that, I conclude my talk, and I'm happy to take any questions if there are.
Well, any questions? I have one question.
Yes.
I recall Dr. Walsh had said the moment seminal vesicles were involved, this should be taken as a systemic disease rather than a local. So he was not very keen on giving local therapy. Instead, he would suggest, ADT. Secondly, the template immediately in N plus is the same as you would do for primary radiotherapy for CA prostate, or the template is different?
In terms of offering adjuvant treatment, sir, for node positive disease, there are indications that if the nodes are less than 2 and if the PSA has become undetectable in the postoperative setting, you can offer them surveillance alone. But if there are other high-risk features, they definitely benefit from adjuvant long-term. Areas of irradiation, if you are offering radiation, we do treat the pelvis as well, in addition to the prostate.
That again undermines my thing that, the toxicity.
Yeah.
If they're just out of surgery, I mean, immediately the continence and all those things go haywire.
We usually incorporate a radiotherapy at around 3 months to 6 months after the initiation of ADTs, because these patients would definitely be put on ADT as well. So we wait for
When
3
you
to
do
6 months.
salvage RT, so at that time, do you include the lymph node mapping also, or just prosthetic bed?
So the pre-RT PSA is what dictates that, sir. So based on the sport trial, where their subgroup analysis showed that the higher the pre-RT PSA, they benefited from incorporation of ADT as well as pelvic nodal radiotherapy.
This
So
is
we routinely do it.
This is in early salvage setting.
In the early salvage setting, you do it when the PSA is on a higher range. If it is between 0.1 to 0.2,
How high?
the cutoff is, I think, 0.3 to 0.5.
Moses, you have answered most of it. Can we wait? If the node is positive, do you give adjuvant immediately or do you not?
So in our center, we routinely offer immediate adjuvant treatment for anyone who's got pathological node positive. So we would start off with hormone therapy, and 3 to 6 months later, we would incorporate radiotherapy as well.
No matter what the PSA level is.
No matter what the PSA level is.
But
there is evidence to keep them on surveillance. If your PSA is undetectable and it was just 1 to 2 nodes, you can consider offering surveillance as well.
so do we have any data to suggest what you're saying? I mean, is there any comparison observation versus early salvage versus?
These are all retrospective data. No prospective trials have been done in this settings.
Because if we are saying that PSA is so sensitive, why not wait? I mean, they must have removed all the nodes
Yes.
as good as the primary. So
Yes, so
why not
that's exactly the reason the guidelines, I think at least one of the guidelines do recommend that you can offer surveillance for these patients as well.
all the three, nice.
Nice, I have not been
Mainly
through.
the
Nice.
EAU suggests that.
Sorry?
EAU suggests that.
EAU suggests that, but AUA doesn't suggest that, and NICE also does. NICE suggests offering adjuvant ADT, not about it.
Yeah.
See, AUA and NCCN is same guys, moving here and
So
there.
I have two questions for you. The first is that what is your prescription for ADT when you're considering salvage? You just mentioned 6 months. Is that a blanket? 6 months, or you would say some patients who are at a low risk, you don't need actually any ADT to go along.
So if we are offering the early salvage radiotherapy at the right time, between 0.1 to 0.2, we don't incorporate ADT at all in those patients. And now the Radicals HD has also come out, which has shown that if you offer 6 months of ADT, that doesn't really benefit patients. 2 years of ADT definitely gives a distant metastasis-free survival benefit.
My last question to you is that do you incorporate PSMA PET scanning before you plan any salvage? Your 0.1, 0.2 is a different matter, but you
Yeah.
often get patients who have come to you 0.6, 0.8.
So,
So-
if the PSA has been undetectable and recurs at a later period of time, there are trials which have shown that PSMA PET CT scan definitely changes the management plan as well. The Condor studies was one. And it showed that even at less than 0.5, about 30% of them would have some PSMA avid disease, and a significant proportion of these patients would have a change in their management plan after you've done a PSMA PET.
To answer your question, I think that ADT 6 months is not working. Yesterday,
Yeah,
one
it's 2 years.
radiation oncologist presented.
Yeah, the
So,
Radicals
American
HD.
Radical.
Yeah.
Yeah.
So they say it's 2 years.
Thank
But
you.
2 years is too much.
Thank you.
Thank you. Next, I'm going to request Dr. Anand Sivaram-Krishnan to talk about adjuvant for bladder, because we are using adjuvant chemotherapy and there is role for adjuvant RT. So I thought it would be good to discuss where to give what.
Good morning. Thank you, Sanjay and the SOGO team for asking me to talk here. So I appreciate giving me a talk where there's no evidence. I'm just kidding. So the talk is about adjuvant radiation or chemotherapy or both. And of all the cancers that we as uro-oncologists treat, bladder cancer is the one that troubles us the most in terms of complications for the patients, in terms of how the patients do at the end of the day. So all of you would agree you would take kidneys and the prostates any day compared to a bladder, right? So the main thing about bladder is how do they recur? You have local regional recurrence, local recurrence, and then you have distant recurrence. Now, previously, we all thought the local recurrence was not too much, 7 to 13%, 5 to 15%, something like that. But now, as we're operating more and more complex cases, we are seeing more recurrence, more percentage of recurrence, around 30 to 50%, and in certain PT4N1 disease, it's around 72%. And all of you know that local recurrence, again, is very difficult to manage, and the patients don't do well, less than 9 months survival. And a lot of the bladder cancer patients also fail distantly. More than 50% fail distantly, right? So you have two things here. One is a local recurrence and distant recurrence. How do we manage both? Therein comes the role of adjuvant RT. The primary goal is to eliminate microscopic disease that may remain following surgery, right? That is one of the goals. Now, local failure, because local occult metastasis can result in seedling and give rise to distant metastasis as well. So if we are doing extended lymphadenectomy to clear all the local disease, why not give RTA as an adjuvant to do the same job for us? That's one concept of thinking about local recurrence. And the other concept is the toxicity due to RT is much less compared to what a local recurrence will do to the patient. So that's some of the hypothesis that was put forth for putting adjuvant RT, right? So the Egyptians were the key persons in this. Okay? They had a lot of bladder cancer. Some of the initial studies by the Egyptians also showed some benefit in adjuvant RT. So this is a phase 2 randomized trial. And this was what was important. The local recurrence-free survival was exceptionally good, 96 versus 69%. So again, bang, right in the middle, flashlights, it showed a good difference. But when you looked at the other parameters like disease-free survival, distant metastasis-free survival, and overall survival, not much of difference. Disease-free survival, some difference, but the other two parameters didn't make a difference at all. So again, adjuvant RT not making a difference, but this paper combined chemotherapy and adjuvant RT versus chemotherapy alone. So disease-free survival and overall survival also favored the addition of RT, but those differences were not statistically significant. Another paper, similar paper, again, more PT3B disease, grade 3 and node positive, and 53% urothelial cancers and 47% SCC. Again, not a huge difference. A meta-analysis, a systematic review, evaluating efficacy and adjuvant radiation for bladder cancer, upper tract urothelial cancer, found no clear benefit of adjuvant radiation following radical surgery. So, no clear evidence, but if you were to give which patients can you give radiation, I think it should be PT3B and above, positive surgical margins and node positive disease. Right? This is how you risk stratify patients. This is a modification of the SWOG data where above PT3B and less than 10 nodes removed, and that was the highest category. Then PT3B and more than 10 nodes removed, next higher category, and PT2 disease. Now to this, I think it's reasonable to add node positive disease as well, because that carries the highest possible benefit when you talk about adjuvant RT. So summary of evidence, can give to PT3B, PT4, N0 to N2 urothelial bladder cancer following RC. And no conclusive data demonstrating improvements in overall survival. Radiation field should encompass areas at risk, plus the dose range should be 45 to 50. Now what are the challenges? Again, not without potential side effects, especially when you do neobladders. Where are you going to give it? On your neobladder, or the cystectomy bed is there. So it will result in a lot of toxicity for the neobladder. Again, a lot of the studies that have been done haven't included cases with neobladder, but some have, and they've said that not much toxicity has happened with the neobladder. So this is something you need to keep in mind when you're talking about adjuvant RT. Let's go to chemotherapy. And neoadjuvant chemotherapy is the standard of care. Now, before we talk about adjuvant chemo, I think we should all get to this point where NACT is the standard of care for bladder cancer right now. There's no arguing that. And what is the potential benefit? 5 to 8% at the best, right, with NACT, but it's standard of care. And regarding adjuvant, this is in 2014, Derek Raghavan's paper. There is no level 1 evidence to support adjuvant chemotherapy, right? This is where we started. And now in all our practices, we do give adjuvant RT, right? There are so many patients that for any number of reasons haven't had new adjuvant chemotherapy. And I think especially in our country, you should have this subset of people that are called neoadjuvant unwilling or unable to have, right? They either don't want to have new chemotherapy or they're not able to have chemotherapy. I'm not talking about cisplatin ineligible people, but people who don't want to have chemotherapy or for any number of reasons haven't had chemo and then had cystectomy directly, right? So the general benefits are the chemotherapy when you administer after removing the bladder, you know what the accurate pathological staging is. So you don't have to treat everybody, and people with low risk of micrometastasis can be avoided, and there's no delay in definitive treatment. And the drawbacks are you don't know if they're chemosensitive, these patients are, whether they will respond when you give chemotherapy, right? Over treatment is an unavoidable problem, delay or intolerability of chemotherapy due to post-op morbidity. So is usually GemCis or MVAC, I'm not going into the details. Some papers, adjuvant chemo, the clinical evidence, there is about 16% improvement in 5-year overall survival, 13% increase in 5-year disease-free survival with the use of adjuvant chemotherapy. Couple of papers, limited evidence. And a meta-analysis of individual participant data of about 10 randomized controlled trials, an absolute survival benefit of 5%. You know, the NACT data is 5 to 8%. These guys are talking about 5%, but this is a meta-analysis, that's a RCT, right? So you have overall survival, RFS, LRFS, and metastatic survival. Not much benefit, less than 5% overall. So again, not robust data. So recommendations as per EAU offer adjuvant cisplatin-based combination chemotherapy to patients with PT3B and above or PT3 and above, PN plus disease if no neoadjuvant chemotherapy has been given. And we won't go into immunotherapy. We all know that it's coming in a big way, and of course ctDNA as well. So adjuvant RT works to a certain extent, adjuvant chemo works to a certain extent. Is there a role in combining both, tackle the disease-free local recurrence, get them local recurrence-free as well as systemic recurrences? The only trouble is you're dealing with both toxicities. Again, this is a paper that supports combined therapy, but not in a setting where the bladder has been removed. And you all know now trimodality therapy has come in a big way, which the basic tenets of it are chemotherapy and radiation. So why not use it in the adjuvant setting? Again, I'm not asking you to collate this data to our current topic, but again, it is possible. But in colorectal cancer, we know that when the primary tumor is present and neoadjuvant is given, it works much better than when the tumor is removed and then you give adjuvant treatment as well. So again, the microenvironment in the body changes when the tumor is there and without. So we directly cannot apply neoadjuvant data to an adjuvant setting. So honest answer is there is no good evidence to suggest a combination therapy. The first paper that I talked about, the Egyptian paper, would be the best example for combination therapy. So emerging approaches, immunotherapy and circulating tumor DNA, I think are the best ways forward. Even now in the US, ctDNA is being used to decide whether patient gets adjuvant chemotherapy or not. I think the best possible example for that would be bladder cancer in our setup. So ctDNA is going to come up in a big way in the future. Immunotherapy, targeted therapy, and combination therapies. So currently, what is happening in our practice? The evidence for adjuvant chemo or RT is not robust. For node-positive disease, I think it will pass through most tumor boards. Chemotherapy will be accepted. And for RT, T3 disease, PSM, and nodes positive, and if they're chemo unwilling or chemo ineligible, I think RT is a reasonable bet. It has to be decided case by case. Thank you very much.
Thank you. The reason for giving the topic to a surgeon was that there was no bias from either a medical oncologist or a radiation oncologist.
Anand, I want to ask you something about CT2. Now, the data on the advantages of neoadjuvant is not as robust for CT2. Now, yes, I understand that CT2 will become a T3 disease in about 30% of patients. But that still leaves 70% of patients who actually do not need, even as per what you're saying, any adjuvant therapy. So is it really strong, your argument strong enough to tell us that CT2 still would benefit for neoadjuvant? Because even if he is, if you look at the other side of the story that you have operated, it is PT2. There is no need for any adjuvant therapy either.
So for PT2, there is no suggestion of adjuvant
so is it
chemotherapy.
Strong? Are we right strongly proposing neoadjuvant in CT2?
I think that's the data is there to suggest if it's a T2 disease, you have to give them neoadjuvant chemotherapy before you do a cystectomy. I don't think there's any debate on that. Yes?
I think the problem, No, the question is your imaging absolutely adequate that this is CT2 will be specimen also CT2? So that 30% is a flaw.
I have just comment to make about adjuvant RT. Way back in 90s, Freeman Hospital, everybody in England was giving a new adjuvant RT which did not work.
400 to 5 for once of 5 days of RT followed by surgery.
Neoadjuvant RT has a potential to downstage.
It never happened.
No difference with overall survival.
It never happened, and then it stopped. Then they stopped.
stopped,
We were giving in Vellore when I was doing MCS, and then it was stopped. Adjuvant RT, I have a lot of reservation about this. First of all, you should not have been talking about this thing. I think Vedang should have been here.
Vedang,
As I said, the reason why I didn't give it to
Vedang is here.
No, I would have loved to see Vedang there.
Yeah,
he's there.
But then
You had a chat with him yesterday.
he's there. So adjuvant RT, I have a lot of reservation right now. Maybe in future, some data come with addition of immunotherapy or target therapy or whatever it is, then things may be different.
So all of these things, immunotherapy, targeted therapy, are all being pushed to the neoadjuvant setting now. I think,
So why are you not worried about adjuvant immunotherapy? It has no side effects. Right. So I was also worried about adjuvant RT about 7-8 years back when we started the trial. Whether it is safe or not. And in the next month, end of September, we'll be presenting the toxicity data of the randomized trial in Washington. 153 patients randomized to post-cystectomy radiation or observation. I was worried whether everybody will be getting bowel obstruction and this and that and people, but it's not the case, I can tell you that. It's been done for squamous cell carcinoma for many years post-op, so it should not be a problem. Whether it improves outcomes, I don't know yet. We will find.
What percentage of those cases were neobladders?
Very few. I think out of 150, only about 10 were neobladders. All of them were RCICs.
And would you change your field for the neobladder
We
patient?
try to avoid the neobladder in the field and treat only the pelvis if there's a neobladder. We don't treat the bed. I don't know if it's the right thing to do or not, but we avoid the neobladder irradiation.
Thank you. Thank you very much, Anand, for that. And the next one would be the newer ways of prognostication to determine adjuvant treatments in uro-oncology. This is a generic topic because radiation oncologists keep pushing for adjuvant treatment. So is there any way of telling us urologists where we should be considering it? Thank you.
So, good morning. Thank you, Dr. Adla, Sogo. So, my topic is on newer ways of prognostication. Good talks have already been given. There isn't a lot to talk about in most things. So, I concentrated my talk on prostate. Treatment of cancer prostate is surgery or radiation therapy, and there is always a debate. But the best approach is individualized. So despite careful consideration, patients may still need adjuvant therapy, radiation therapy or ADT. The prognosis we know is determined by the T stage and the grade grouping. But, and that's basically because of the fact that as the Gleason's grade increases, the biochemical relapse rates, they really climb up. But does this determine the adjuvant treatment as well? So let's discuss this adjuvant treatment. Very nicely summarized, but I'll probably go a little bit deeper. So we'll talk about some historical aspect, then new tools, then little pragmatic approach. Historically, randomized trials have shown the benefit of adjuvant radiation therapy. They have shown statistically significant benefit across all trials. There's a fin prostate group benefit. This is the ARO 9602. There was statistically significant benefit. Then these forest plots, then the EORTC BOLA trial, benefit, benefit, and benefit. Benefit, benefit. And till 2020, the NCCN guidelines about adjuvant radiotherapy would talk about indications of adjuvant RT to be T3, positive margin, seminal vesicle involvement. But as 2024, or maybe probably last year as well, the things changed and the word historically has been added to adjuvant RT. So all that randomized data, is that all wrong? That was really convincing, right? That's probably because, there were issues that these randomized trials investigating the role of adjuvant RT were not able to talk about how to defer treatment or how to discuss treatment for recurring patients. Then most patients had detectable PSA at the time of randomization. So many of them were receiving salvage RT actually rather than adjuvant RT. RT dose was also low as per current standards. We know that this is the dose response curve for CA prostate, and as you increase the dose, the benefit increases. Even in the comparator arms were very non-homogeneous, they were uncontrolled. Patients were treated with several options, and the salvage RT was consistently higher than 1 nanogram, which is quite high as per current standards. So therefore, the phase 3 data actually did not help. So what came next? Some newer genetic tests were approved in the meantime. And this is the only one which is relevant to this talk on adjuvant, which is the Decipher biopsy and Decipher postoperative, which is relevant for the postoperative radiotherapy. So this started with this report in 2016, where they validated a 24 gene predictor. They first did a training cohort, and once the training cohort was approved and it met the standards, then they went to the validation cohort. This is the low POTOS versus high POTOS. Low POTOS versus high POTOS, and there was benefit when the POTOS score was high. This benefit was for the adjuvant RT. And this another report, again the same thing, genomic classifier, and this was more close to what it is today, the Decipher. And these were the three parts at which the curves opened up statistically significantly, less than 0.4, 0.4 to 0.6, and more than 0.6. And this is the benefit of adjuvant RT. So these are the patients who received adjuvant RT at GC score of more than 0.4. And you can see that there was a benefit of giving adjuvant RT to these patients as compared to salvage RT. Not that these patients did not get any RT. In the meanwhile, ESRT data also matured, early salvage RT. And I'm not going to go in all this thing, but I'll just talk about the artistic meta-analysis. And these are the trials that it incorporated: Radicals RT, Getuk AFU, and Raves trial. More or less similar trials. At least the radiation dose was similar, that is a relief. And it showed, and this is what we all know, practice, that ESRT and adjuvant RT are similar to each other with just a 1% absolute difference. And therefore it was, moved in the NCCN and all the guidelines. And now we talk about how we should, follow the PSA and go for early salvage RT. But there is a caveat to this meta-analysis. Men with adverse features were underrepresented. Gleason score greater than 8 was quite less, 9 to 17%. T3B also quite less, 18 to 21%. As sir was saying, T3B is a different entity. T4A, just 1%. Patients with pathological node positive were excluded in the 2, just included in the radicals cohort. And 5% only representation was there. So there is a caveat. So whatever you are seeing is not really for these groups, is it? And these high-risk factors are the ones that influence mortality. This is not just biochemical progression-free survival. So what's happening in the real world? This paper shows that almost all patients, a lot of patients who are having positive margin T3, T4s or high Gleasons ultimately end up getting salvage RT. So it's not like that you are saving it for many of them, most of them. And then they are getting it at a PSA value of 0.5, which is a little higher than what we would like it to be. This is the 2022 paper which was presented a while back. And what I would like you to see in this is this aspect of the paper. Aspect number 1. More than PT3, more than Gleason score 8 or N1, there is a statistically significant benefit of adjuvant RT. Fair point. It was there in the other trials as well, so why not? But that's not the but that's not where it differs, right? It differs when you follow PSA. That's what ESRT is about. You follow PSA. PSA you consider the most sensitive indicator after filtering the patients with adverse histology. But you do the same thing and you remove the patients with persistent PSA, adjuvant RT is still benefiting. Similarly, T3 and PL and N0. So you are just taking these patients, adjuvant RT is benefiting. You remove the patients with PSA, that means the ones with you would have considered for ESRT or SRT to that matter, again statistically significant benefit. T3 margin positive benefit, you remove PSA, still benefit. So these are the things which are, while they are, they confuse our simple view of the world, but then one size fits all has never been the policy. If one size fits all is not for adjuvant, it is also not for early salvage RT. And therefore, these prognostication models come in. This is the genomic classifier, the decipher. And this paper first reports that there is a statistically significantly worse outcome with a higher stage T3b, T34, higher Gleasons, lymph nodes, and a decipher score. These are all independent variables in the multivariate model. Then this paper reports that if the risk score is more than 2, that means if there are 2 of these things or more, then there is a significant benefit of considering adjuvant RT. Now, this is one additional way of choosing adjuvant RT. You can choose it by stratifying the accumulation of risk factors, or you can do it by using the risk score. So ESRT principles are not necessarily on multiple risk factors. More than one risk factor, please use your best judgment. T3, T3b, multiple margins, Gleason score 8. 58 seconds. Okay, decipher score is the most promising genetic marker for adjuvant therapy. Please also note the fact that all the data discussed above was about mortality and not just biochemical control, and therefore is quite relevant. I'll quickly go through adjuvant RT for lymph node positive. This is the retrospective paper. I just want you to understand that as far as retrospective data is concerned, we should not be offering it to low Gleason score, even if the node is positive or the number of nodes is less and the Gleasons or there isn't accumulation of risk factors. But as the practice goes, everywhere around the world, for node positive patients, ADT and adjuvant RT are given because of the benefit, and similar recommendation is in the NCCN as well, although the NCCN also talks about following the PSA and waiting for the PSA to be more than 0.1. With this, I thank SOGO, Dr. Adla, chairpersons, all organizing teams for this opportunity.
Thank you, Dr. Gagan, for nice summarization of adjuvant radiotherapy. So, in your clinical practice, whom do you select for adjuvant therapy in prostate?
Sir, adjuvant therapy in prostate, I recommend for patients in which there are 2 risk factors, and one of them, if it is T3b, we tend to be a little more, tend to be a little more biased. So if it is T3, if there is a focal positive margin, let it be. The multiple positive margins or the positive margin is a little bit doubtful as per the surgeon. It's a little bit of a clinical decision. It's a bit of a teamwork. So we are, and of course, the most important marker is a persistent PSA. I mean, I'm assuming that you are saying in a non-detectable PSA, what will be for adjuvant. So yes.
And node?
Nodes, of course. Nodes should get RT. Node should get RT unless the Gleason score is low. Unless the Gleason score is 6 or low. That I've never seen really. Gleason score 6 or low.
Any more comments or?
Thank you very much, Dr. Gagan. We'll move on to the next one. Rahul Jenna talking about adjuvant treatments when patient is on ADT. Every prostate cancer patient, we keep starting them on ADT. So I just wanted to know what is there currently in literature about maintaining their BMD.
Right. Thank you. Sorry. Thank you, sir. So, this is actually a very straightforward topic. If you read from the book, you'll understand. But all of us keep on seeing these patients in our practice. And I will try to touch upon those things which have generated a little bit of controversy due to change in recommendations in the recent years. So, why is it important to know about this topic? It is because all of us who see metastatic prostate cancer, we see patients, the commonest presentation is to the bone. And when we start them on ADT, they obviously have bone loss. And sometimes we even have seen patients coming with fractures. So what is it that causes these fractures? Is it just the weakened bones? The real answer is that when you have androgen deprivation therapy, even your muscles get weakened. There is a imbalance between the muscles and the bones, and these skeletal related events are actually independent predictors of mortality and morbidity. And it has traditionally been thought that longer the duration of androgen deprivation therapy, more potent agents you add, the higher are your chances of having bone loss. So this diagram, it actually shows you that after 12 months, you have a significant bone loss in your lumbar spine after 12 months of starting androgen deprivation. And there is a difference between the androgen deprivation you do for non-metastatic and for patients who have metastatic disease and castrate-resistant disease. For non-metastatic, it is often reversible. For metastatic disease, it's a lifelong androgen deprivation you have to do. And for CRPC, other mechanisms come into play which independently cause bone loss. Now, I have met people, and for a long time, even I used to think that zoledronic acid, the landmark trials which had zoledronic acid in the treatment arms, what was the rationale behind using it? The only purpose was not just to prevent bone loss. The reason why zoledronic acid was added was because there were multiple studies which showed that it has a direct inhibitory effect on osteoblastic and osteolytic metastasis of prostate cancer in the way that it stops the growth of prostate cancer cells in vitro. It promotes the apoptosis of these cells. So I don't need to label this diagram. This is a landmark diagram of the Stampede trial, and there were 4 arms which evaluated the effect of zoledronic acid, the arms A, B, C and E. And if we look at some of the key trials of zoledronic acid in metastatic prostate cancer, there are mainly 3 based on which the recommendations were made. One is the CalGB, the Stampede and the ZAPCA. Out of these, Stampede showed the least incidence of skeletal related events, only 27%. And this publication conclusively said, don't use zoledronic acid routinely, use docetaxel, because zoledronic acid does not have any advantage. Some of us stopped using zoledronic acid for all patients, and some of us continued using zoledronic acid for all patients even after this. So who got proved right at the end? That is what we are going to see now that we have the long-term follow-up data. So what the guidelines advise at this stage is that you have to identify people who have a risk of sustaining a fracture. One of the ways to do that is to do a FRAX questionnaire. To be honest, I have never done it. I have always gone directly for a DEXA scan. So the FRAX questionnaire, it has a list of questions, lists all the risk factors, and number 10 in this is secondary osteoporosis. So it basically means hypogonadism associated osteoporosis is known as secondary osteoporosis. So it tells you the overall risk of having a major osteoporotic fracture and the risk of having a hip fracture in the next 10 years. And once you have an estimate of the risk factor, if the risk is above the threshold beyond which you would advise advise bone protection agents, you use bone protection agents, and in those who are not at risk, you do not use them even if they are on prolonged ADT. So the recommendation is that you have a DEXA scan at baseline, and if the patient continues to have ADT, you repeat a DEXA scan every 1 to 2 years, And if the patient has already been started on bone protection agents, then you repeat a DEXA scan every year. Based on that, this is purely for hormone-sensitive metastatic prostate cancer. Based on that, you advise weight-bearing exercises. Weight-bearing exercises are not exercises where you lift weights. They are those exercises which you do while bearing your weight on your legs. So mainly aerobic exercises like running, cycling, walking. And you have calcium and vitamin D. You have to limit alcohol consumption, smoking cessation, calcium and vitamin D supplementation. If your diet doesn't give you an adequate amount of calcium, there are ways to calculate this for an Indian diet. Most of the websites, for example, Prostate Cancer UK, they mention calcium content of Western diets. And then if you have proved that you have a treatment-related bone loss, you give them alendronate or denosumab 60 milligrams subcutaneous every 6 months, or zoledronic acid 5 milligrams annually. Side effects you have to watch out for. The most, probably the most devastating side effect is osteonecrosis of the jaw. That is why it is important that you have a proper dental checkup, and if any dental surgical work has to be done, that has to be completed before starting ADT. The risk of hypocalcemia increases, especially if you have widespread blastic mets, renal impairment, pre-existing hypoparathyroidism, or vitamin D deficiency. So we again come back to this. Now, this is an updated follow-up of the Stampede trial, which was presented in ESMO 2023. So they concluded that their previous publication, which said do not use zoledronic acid, it probably did not have sufficient follow-up to make this recommendation. Now that they have followed up these patients for 5 years and more, they have found that there is a 7% difference in the risk of fracture between those patients who did receive zoledronic acid and those patients who did not. And it was statistically significant. So in the Advanced Prostate Cancer Conference, the data was presented by Prof. Noel Clark. He is one of the lead investigators, along with Prof. Nick James. He is one of the lead investigators of the Stampede trial. And the entire interview and the transcript is available on Euro Today. The data he presented was that there is a 40% risk of fractures for metastatic hormone-sensitive prostate cancer, as opposed to the earlier figure quoted in their paper, which was around 25%. He says that the Frax tool is unreliable, and it makes sense because the Frax tool was developed for elderly women post-menopausal to calculate the risk of osteoporosis, and only 25% of this population, which was used to calculate this, were men. At the contrary to our previous beliefs that addition of drugs like enzalutamide, abiraterone increases risk of bone loss, on the contrary, it actually decreases the risk of bone loss. This was shown in a meta-analysis which was done in and around the same time by the Stampede group of their own studies, and this has also been shown on their prolonged follow-up. And they recommend that everyone should get a bone protecting agent irrespective of their Frax score. In CRPC, the evidence is more clear. Anti-resorptive agents are recommended for prevention of skeletal-related events in the doses that I have mentioned here on the slide. The doses are more frequent and larger doses than you would give for hormone-sensitive setting. Again, there is no consensus on this. A drug holiday at 3 to 5 years is recommended, but these drugs have been known to accelerate rebound bone loss. So we have to keep an eye on that and restart these drugs when we have bone loss or a new fracture. So summary is that there are clear recommendations in castrate-resistant setting, but the indications in HSPC will probably evolve into recommending this for everybody. And the more potent agents like abiraterone and enzalutamide do decrease the risk. Thank you.
Any questions? Complete?
Yes. Thank you very much. That was very good. So as of now, you didn't say for a patient who is metastatic hormone sensitive, it is 60 milligrams of denosumab once a 6 months if they have got normal bone mineral density at the outset. Is that what it is? And 4 milligrams every 6?
As of now, if the bone mineral density is normal, the fracture risk is less than 20% for overall fracture and 3% for a hip fracture, you don't give anti-resorptive agents. You give only supplementations and vitamin D.
Okay.
But the updated results of presented at APCC have said that even for people who have normal densities and were in zoledronic acid, there was fracture prevention. So probably when they update these NCCN guidelines next year, we will have a blanket recommendation
That
for
all of them.
For all of them.
Thank you. Now it's a Ferring Pharma talk from Dr. Raghavan, maximizing ADT in 2024 concepts and controversies.
Good morning all. Good morning chairpersons. Rashtrapati ji. Thank you for this opportunity. It's a sponsored talk by Ferring Pharmaceutical. There are two disclosures to make. One, I have zero financial interest in Ferring Pharmaceuticals. Second disclosure is that I'm a great fan of Degarelix. I've made these two disclosures. I'll start from there. The topic given was ADT in 2024. I changed the topic as maximizing outcomes and minimizing side effects. And in the next 5 to 7 minutes, I've been given 15 minutes, but my intent to finish in 5 to 7 minutes, I need to prove to you that we need to maximize outcomes and minimize side effects. That's all. So all of us know the types of ADT available. Are all ADT same? We all know that it is not the same. We have the agonist, which accelerates the production of FSH-LH and then suppresses after some time. And then we have the antagonist, which blocks it off once and for all. They are two different things. With that, we know that with the agonist, there is going to be a testosterone flare, a FSH flare, and a microsurge, and there is going to be oscillation of the testosterone level. That's the principle behind this. After that, everything falls in place. Now, according to various guidelines, when should we use antagonist? We should be using it at least by guidelines whenever there is an impending, urinary obstruction, cord compression, anything, or a patient with a high cardiovascular risk, we are supposed to use it. But in India, everybody is a walking bomb of cardiovascular risk and a diabetic as well. I say to my patients, every Indian walking in the road is a diabetic unless we prove otherwise. We have to prove them that they are not. So let's quickly look into the maximizing outcome, how to maximize outcome. And for that, let us look into direct and indirect markers, namely what is the PSA response, what are the durability of response, what is the testosterone suppression, and how the microsurge has a positive or negative impact, and what is the value of FSH in the context. Okay? Now, for the next few minutes, don't even bother to look at the slides, just look at the graph and listen to me. PSA reduction with antagonist with agonist, graph clearly shows that the antagonist will suppress it quickly and intensely and for a long time. The agonist seems to be crawling behind like a Fiat car. The PSA recurrence with antagonist versus agonist in CS21 study clearly shows that Degarelix or any antagonist will cause intense and prolonged suppression. That is, you are talking about up to 1 year. The differences are quite very clear. Even at 1 year, the suppression is different between the two drugs. Multiple RCTs have been done, and this is the pooled data. Once again, look at the right side of the chart. Even for patients with a PSA which is elevated, Degarelix causes prolonged suppression compared to leuprolide. So let us go into the next surrogate marker, which is the testosterone suppression. We all know that agonist will flare and then suppress. We all know that. And we also know that agonist will also cause testosterone surges as well. As expected, the antagonist suppressed it intensely almost on day 1 and kept it that way till at least 1 year. Same microsurges, you see the flare and so many oscillations in the graph. The right side graph, you clearly see the oscillation that keeps on going in the testosterone levels. when you use a agonist. Right. Then we are all taught, right from my urology days, that whenever you start goserelin, give calutide. Does calutide work? Answer is sadly no, it doesn't work. FSH and LH reduction in agonist versus antagonist. We clearly see that both of them cause LH suppression reasonably quickly. Agonist a bit late, but antagonist instantaneously. But what is more important is graph 2, which is the FSH suppression. And why is FSH important? Because you will see in next slide. FSH is important because it has effects not only on prostate, but also in the bone and the adipocyte and the cardiovascular, the vasculature as well. So, when the FSH levels are still high, the patient has an increased risk of cardiovascular and cerebrovascular accidents. And that's what is the biggest problem with the FSH level in the prostate cancer setup. FSH also has an impact on the bone mass, as in when the FSH levels are high, the bone loss is high as well. Okay? Let us look at it in a different way. In a bone metastatic patient where we know ALP is an indicator of bone metastasis, the intensity of suppression of the ALP by degarelix is far higher and compared to leuprolide. This should have come in the next section, but the next section is the, so now we have just crossed the maximizing outcome. We have clearly understood that when you use an agonist, you cause intense, immediate suppression and it remains that way without any oscillations. Okay, now come to the side effects. We all know what are the side effects of ADT. All of us know that, just to capture a most important: cardiovascular, metabolic syndrome and obesity. We all know that ADTs are not the same. There are some ADT which has less cardiovascular side effects than others. And this is the FDA warning clearly shown. This is when the goserelin was available before degarelix came, telling that you have to warn patients of the cardiovascular risk when you administer these drugs. Then degarelix got introduced in 2009-10 and we have multiple studies, direct studies, these two studies clearly showing the severity of CV event when you use a agonist versus antagonist, and this is in spite of eliminating other factors. The singular factor that has been responsible for CV event is a agonist versus antagonist use. You look at the other factors also taken into consideration: statin use, alcohol, smoker. In spite of all these things, that stands apart in the hazard ratio. And this is this meta-analysis of all the trials done, which once again clearly see the diamond plot there, very clearly showing that it is the antagonist versus agonist which matters in CV protection. Major adverse cardiovascular event, MACE. Once again, if you look at the last point, hazard odds ratio is 0.42. At odds ratio of 0.42, an extremely significant odds ratio in terms of pointing to the direction that CV event, MACE events with degarelix is much lesser compared to antagonist, agonist. In addition to that, as we progressed, we thought we are taking care of cancer control better by adding new drugs, and with that we added new problems. That is the chart to tell you what all new problems we are adding to each patient. Just this chart is very scary, but in spite of it, we add it every day. Yeah, hypertension. No drug is an exception. I mean, don't think apalutamide is better than darolutamide. Nothing. Everything causes hypertension, hyperglycemia. Everything happens with all the drugs. The problem is the fact that we, as human beings, have been using the sex hormones as a natural protection for our. Oh, I thought 7 minutes. Okay, I'll finish it quickly. Metabolic syndrome. Metabolic syndrome, very clearly, this is what happens when you start ADT for these patients. Yeah, this one chart. The most famous ADT that we use in India is orchidectomy. Extremely scary. The amount of CV effect of orchidectomy is just unspoken. And I am doing a study in our hospital, and those results, the early results are unspeakable. The amount of cardiovascular risk that these patients pose. Just a summarize of a meta-analysis clearly showing antagonist is much better compared to agonists when it comes to cardiovascular, musculoskeletal event, and overall mortality. With that, I finish. I'm so sorry I exceeded by 1 minute.
Thank you. Any questions?
It's always interesting to listen to the arguments for LHRH antagonists, and they are so convincing most of the time.
Thank you.
But fact of the matter is that these are all the pharmacological hypotheses. Unfortunately, most of them have not turned out to be that beneficial as far as the randomized data is concerned, which is the razor edge for any clinical usage. What do you have to say about that? Do we have to have better biomarkers? Do we need to select the patients better? What is it that you would like to change so that your love for degarelix or love for LHRH antagonists can reach more people?
We don't have any better drug. The problem, I'll take 1 minute. The problem is about agonist and antagonist. It's all about the fact that the testosterone get lost. That the whole cardiovascular morbidity related that is the loss of testosterone and increase in FSH level. And the project that we are doing in our hospital also shows the same thing. We do not have any mechanism to do that other than using degarelix today. We don't have anything better than that. Do we have biomarkers or genetic analysis in future which can help us to understand this better? Maybe. But the problem in India is that when we do the cardiovascular assessment for all our patients before going to ADT, we made it mandatory as a part of a project. We realized that a lot of patients are already at cardiovascular risk at the start of the ADT itself. That is what we are finding. There is. There is, okay, since the advent of all these discussion, there is a group called PCCV group across the whole pan Asia. I think sir is also part of the group, or at least Ganesh Bakshi is part of the group, where we are looking at and a comprehensive risk assessment tool is available. I'm happy to share with you the risk assessment tool for patients to go before starting ADT. You can run the risk assessment tool and then decide how you are going to use it. It's available. Online, it's available.
So, Dr. Raghavan, if you can address this.
Sorry, I'm so sorry.
Yeah, the most of the studies that actually you have quoted, those are not randomized trials. There was only one randomized trial which was done between agonist and antagonist, particularly on cardiovascular safety. That was pronounced trial. If you can actually throw some light on the results of the pronounced trial.
I have to show a chart on that, and can I just?
I think we have to go for a next panel discussion.
Okay,
maybe.
just 2 minutes. I'll tell you the pronounced style problem. The problem with the pronounced style is that everybody was screened before you start, and everybody was constantly monitored during the trial.
So that's what a trial is.
Well,
when you are
that's
doing
what
a trial, you have to monitor them.
It doesn't happen on real life. The real life.
Yeah,
is
that I
you put
understand. But
patients
in
and
trial,
forget
the
them.
patients are actually monitored more closely. But can you tell me the results of that pronounced trial? What happened to the trial?
The trial at 1 year, there is no difference between antagonist and agonist.
So that was the only randomized trial actually who said there is no difference between agonist and antagonist in terms of cardiovascular safety. That was meant only to look at the cardiovascular safety.
In a very controlled circumstance.
Okay.
In a very controlled circumstance.
Thank you very much. I think we should
Thank
move
you.
on.
So,
And
Dr. Amit Joshi, please come. There is a panel discussion on androgen deprivation treatment. Are they same? You can.
Yeah.
Request your panelists.
So I think most of this have been, at least few points has already been discussed. So I will try to quickly sum up the and the real life situation. So I would like to invite my panelists for this, Dr. Rupesh Shah, Dr. Raj Patel, Dr. Indranil Ghosh, and Dr. Amitabh Ray for this discussion. Challenges which defines the, or which is one of the most important hurdle for CAR T cell availability or use. But this field is evolving very rapidly, and I think next 2 or 3 years we will have a plethora of them. So this is one of the structure of the CAR T cell. It's a tumor cell, and this is the tumor target antigen, and this target antigen will define the T cell therapy for that. So this target antigen can be a carbonic anhydrase 9, it can be a CD70, it can be CMET, and it can be a MUC1. So there are two main CAR T cell which are being available or which are being used in a clinical setting, is the carbonic CAR T cell against the carbonic anhydrase 9 and the CD70 CAR T cell. And so this tumor cell expresses the CD70, and this is a CAR T cell which has been genetically modified to express the CD70 antibody against that. So whenever this tumor cell which harbor the CD70 as a surface comes in contact with this T cell which has a anti-CD70, so this tumor cell will have a lysis, and the T cell will directly kill the tumor cell. But as I told you, with the availability of the multiple antigen on the tumor cell, it's not possible to target each and individual. So the scientists are working on developing a multi-targeted T cell which have a multiple receptor against that. But at this point of time, the most studied for a RCC is the CD70 target CAR T cell. So that I told you, the CD70 is a membrane protein that plays a role in tumor proliferation and immune cell evasion by evading the. So the preclinical data has shown that CD70 CAR T cell is effective in inhibiting the tumor cell growth in a tumor which expresses the CD70. So this is one of the trial which is very recently published or presented in the American Association of Clinical Research. CTX130, it's a CRISPR-Cas9 engineered chimeric T cell against the CD70. So it's a engineered T cell which is having a CD70 against the CD70, and this trial was known as Cobalt RCC study, and this trial has presented so it has around 15-20 patients, and this, if you see the result of this trial, it suggests that one patient has, so all relapse refractory patient post TKI, post immunotherapy. So these are the patients which having a most resistant disease, not much option left. And when the T cell was given, the CD70 CAR T cell given to this patient, one patient achieved a complete response which is exceeding over 36 months, and 12 additional patients have a stable disease which is exceeding 18 months. So that means this with phase 2 and the side effects which we are worried about, the neurological, what we call as a syndrome of expected release of the certain the interleukin. This was not seen in too many cases. So with this phase 1 data, first successful use of a CAR T against the CD70 is available, and the scientists are working on this. So I think the computer doesn't like this CAR T cell. So the other CAR T cell apart from this is the LO316. So these are the two CAR T cell which has passed the phase 1 data. One is the CD70 again, and this is also the first one is a CRISPR edited CD70 CAR T cell, and this is the anti-CD. So if you see the result of this, the LO316 study, 33 patients have a overall response rate at the end of 6 months, and 100% patient at the. So these are the very early data which has shown promises, and the phase 2 trials are ongoing. So I think next 2 or 3 years we will have plethora of the T cell. One is I told you about the carbonic anhydrase 9, and the other next is the CAR NK T cell. So apart from the T cell, the CAR NK cell which have a chimeric receptor against the certain antigen. So this is the new future for a CAR T cell therapy. So what we can conclude that the CAR T cell has just entered into the solid tumor era. There are 2 trials, phase 1 trial which has shown the safety of this therapy, and some early data of efficacy in this group of the other drug which has come into the RCC is the belzutifan. It's a HIF1 inhibitor, and in the preclinical model and in early phase studies, this has shown that it works. and we all know that it targets the HIF2 alpha, and this is a key enzyme which regulates the cellular response to the hypoxia. If we block this drug, the subsequent pathway of this, if we block the HI1 alpha, the tumor which requires the angiogenesis will be further halted. So this is the Light Spark 005 study. In this, the patient of a relapsed refractory, that is more than 1 to 3 prior lines of therapy, post VGF TKI, post antidiuretic, receive the everolimus, which is the standard of care at this point of time, versus the belzutifan. That's and the primary endpoint was PFS and the secondary endpoint was OS. And if you see, all risk patients were available. And if you see the primary endpoint of the study, this green curve is for the belzutifan, and this red curve is for the everolimus. And this one of the primary endpoint of the hazard ratio of 0.75, the PFS favors the use of belzutifan in third line and beyond in a clear cell RCC. Regarding the OS endpoint, the data is still maturing. Numerically, it seems to be better. The 18-month OS rate is close to 55% compared to the 50.6 in the, but statistically is not significant, but in due course of time, this may be positive. So there is a clear-cut signal that belzutifan in a clear cell RCC has inroads, and it may become one of the standard care in due course of time. And side effect, the only worried side effect is the hypoxia, which is more seen because of the blockage of HIV. Rest all were comparable with the everolimus. The third TKI, which is coming in the management of is the tivoxantinib. So this is one of the another TKI which is being used post failure of 2 to 3 prior VGF TKI, and this tivoxantinib versus sorafenib, this was the study, and this study had shown that there is a PFS benefit, although it has not demonstrated because of the crossover, the survival was not seen, but definitely the PFS benefit. So tivoxantinib is the next. So after the axitinib or cabozantinib, this is one of the TKI which can. So other next very exciting is the gut microbiota and immunotherapy in renal cell carcinoma. So what we used to be in our ancient Ayurvedic Vedas, that gut is most important, and now with this science we are proving that the gut microbiota plays a very important role in modulating any immunotherapy, not the lung cancer. So as already, and the retrospective data has shown that patient who used multiple line of antibiotic while on immunotherapy has a poor survival compared to those patients. So that means the antibiotic has some role in modulating the gut microbiota, which then influence the response to the immunotherapy. So this is one of the randomized trial of a combination of Nivo-Ipi with the, this is one of the strain of the bacteria CBM 588. So one arm patient, it was the phase 1 study of the efficacy or the safety of this Nivo-Ipi combination with this bacteria CBM 88. So patient of a clear cell RCC, Nivo-Ipi versus Nivo-Ipi plus that particular strain of the bacteria. And CBM 588 is a live bacterial product containing the Clostridium butyricum, a butyrate producing anaerobic spore forming bacteria, first isolated from. So this is one of the bacteria from the Clostridium species. So, and this trial was positive trial. The progression-free survival was better in the Nivo-Ipi versus the similarly the Nivo-Cabo arm also used the same bacteria in there, and this was also a positive trial. So that means the combination of a 2 immunotherapy with bacterial supplement, whether in IO plus IO or IO plus TKI, has shown. So this has inroads. If you see the response rate of a group of patients who have supplementation of that particular CBM 588 bacteria, so this has definitely improved. If you see the survival of different cancer therapy era, so we started with the interferon era, then we came, if you see the 3-year survival, this is gradually increasing. At this point of time, we are at this era. So, but I think it's at some point.
Excellent, Dr. Amity. Thing is this Carpicel specifically it is used for renal cell alone? Do you think that in other urological malignancies it will come?
So
and if so, which one?
Yeah, prostate is there one trial which has shown some positive. So ultimately, the problem which I told you, in the hematological malignancy, you have one target like a CD20. So you can make a CAR T cell against the CD20 and then you can use that. But in a solid tumor, and the availability or the reach of the CAR T cell in a hematological malignancy, this question doesn't come. But in a solid tumor, the T cell has to reach to the tumor microenvironment. So now people are trying to do, and the other problem is with the specificity or there. So CAR T cell with the NK CAR T cell is the next future. So in prostate, the phase 2 data, phase 1 has already completed. and that is also appear. So after the immunotherapy, the next era of the treatment in solid tumor is the what we call as a cellular therapy. That is the next future in.
So second question is gut microbiome. Yeah, where in the clinical aspect, where it is going to come, because
Yes.
it is, yeah.
So in those two studies, this was the safety study where the increasing the dose of the CBM 588, that the Clostridium botulinum, indirectly affects the safety of the patient. So the patient number were hardly 15, 20. So what they established that if you increase the dose, it was a dose finding study of that particular bacteria. So they find that this dose is safe. Patient is not, and indirectly those who receive the supplement has a substantial difference in the both the PFS and the response rate. So the phase 2 study has already started of this supplementing the bacteria with the IO.
So exciting.
So it's very
Thank you.
exciting.
Yeah, thank you very much.
Thank you.
So we will go to the next talk, addressing favorable risk metastatic risk carcinoma, objectives and treatment endpoint, by Polomi Basu.
First of all, thank you for giving me this opportunity. My talk will be on mostly the management of metastatic RCC patient, mostly good risk subgroup. So first of all, coming to the first line treatment, what we have option. We usually, whenever a metastatic RCC patient comes to our OPD, we have a HINS criteria, we have MSKCC criteria, and according to the score, those patients have favorable risk. We have lots of option. Those have more than 2 risks. We termed it as intermediate, and if it is more than 3, then it is termed as poor risk. Now, coming to the NCCN guideline, which we usually follow in our day-to-day practice. For favorable risk group, we have options of active surveillance. We have options of single agent anti-VEGF. We have options of doublet immunotherapy, where we can use Nivo plus cabozantinib, we can use axitinib plus pembrolizumab, even we can use lenvatinib plus pembrolizumab. Now coming to the biologic rationale for combining this doublet immunotherapy, whenever we combine this Nivo plus Cabo, it enhances the tumor cell T cell mediated more cancer cell death. Why we combine anti-VEGF along with immunotherapy? Because this anti-VEGF therapy may prime for better effect with anti-PD-1 or anti-PD-L1. Now coming to Carmina trial, where it's a prospective multi-center open-label randomized phase 3 trial, where they are randomized into one arm which received nephrectomy followed by sunitinib as an adjuvant therapy, 50 mg dose, once daily dose, 4 week on, 2 week off. And the second arm received only sunitinib 50 mg OD dose, 4 week on, 2 week off. The primary endpoint was overall survival, and the secondary endpoints were progression-free survival, overall response rate, and as well as the safety. Now coming to the result, and the results showed that those arms received only sunitinib. The median overall survival was much more, 18.4 months in the sunitinib group, whereas nephrectomy followed by sunitinib, it was 13.9 months. So we can say that when patient performance status is good, patients have minimal extrarenal disease, in that case only nephrectomy makes sense. If patients have poor PS, poor risk, and large primary tumor as well as extensive extrarenal disease, in that case nephrectomy does not make sense. Now coming to the CheckMate 214 data, where this again a phase 3 study. There compare sunitinib versus nivolumab plus ipilimumab, and this trial showed that the overall response rate was much more in the single agent sunitinib arm, which was 54% overall response rate, whereas in the nivo plus ipilimumab arm, it was only 29%. And look at the median PFS. Median PFS was 27 months in the sunitinib group, whereas in the Nivo plus ipilimumab group, it was 17.8 months. So again, sunitinib have better result in a favorable risk group of patients. Now coming to the Keynote 426 data, where they are using Pembro plus axitinib versus sunitinib. And in this particular trial, they showed that the 12-month overall survival was much more in the doublet immunotherapy group. It was around 90%, 12-month overall survival was 90% in the pembrolizumab plus axitinib group, whereas in the single agent sunitinib, it was 79%. So there was a consistent benefit whenever they are using doublet immunotherapy for metastatic RCC patient. Now, coming to the overall survival, PFS and overall response rate data, again in the pembro plus axitinib group, complete response rate is much more, which was, we can say, 11%, whereas in a single agent sunitinib, it was almost half, 6% complete response rate in the sunitinib group. Now coming to the Javelin data, where they are using avelumab plus axitinib in the treatment naive advanced RCC patient. Now coming to the toxicity, whenever we are using immunotherapy, there is most chances of developing mostly patient present with immune-related hypothyroidism, immune-related rash, dermatological toxicity, some of the patient present with immune-related pneumonitis, immune-related colitis. Those patients are on sunitinib, mostly patient presents with hand-foot syndrome, diarrhea, nausea, fatigue. Sometimes their patient may be present with grade 2, grade 3 transaminitis. So these are the adverse effects which we usually find in our OPD. These are the immune-related pneumonitis, immune-related carditis, enterocolitis. And when it is grade 2, we have to hold the immunotherapy and we have to start methylprednisolone as early as possible as a dose of 0.5 to 1 mg per kg per day. If the grade is more, then we have to discontinue immunotherapy and have to closely monitor. If there is immune-related hepatitis, sometimes we add mycophenolate mofetil. For pneumonitis, we have options of methylprednisolone. So we can say that now coming to the summary, we can say that mostly for good risk patient, if patient is asymptomatic, there is low burden disease burden is low, in that case, active surveillance is an option. We have options of single agent sunitinib because we have enough data where they are comparing sunitinib versus nivo plus ipilimumab. In that case also, sunitinib have much more benefit, overall response rate, even PFS is much more in the sunitinib group. Those patients are affordable, there is no financial toxicity. We can use pembro plus axitinib because we have keynote data where we can say that yes, overall survival, there was a persistent overall survival benefit whenever we are using pembro plus axitinib. So that's all from my side. With this, I would conclude my talk. Thank you.
Thank you. The cytoreductive nephrectomy, actually, all the trials is on TK era, and nothing has come in the immunotherapy era. And immunotherapy era, long back we were doing cytoreductive nephrectomy, so the immunological treatment has come back. So do we think that all the data we have to discard and start new, or is it valid in the current era of immunotherapy also, the avoiding cytoreductive nephrectomy?
Yes, we can use cytoreductive nephrectomy if patient is symptomatic. If there is oligometastatic disease, we can use cytoreductive.
That is good prognosis. And intermediate 1-2, between this 1-2.
If patient is intermediate or poor risk, we have now enough data of immunotherapy. And in that case, their overall survival is much more. So we can use this doublet immunotherapy, even is immunotherapy.
No, cytoreductive nephrectomy can be advised in that intermediate.
Cytoreductive nephrectomy mostly for a good risk patient. And for selected patient, those patients are only have oligometastatic disease or any symptomatic.
So,
Thank you.
Thank you very much. Yeah, Amiji.
So the only thing is that regarding this issue of the cytoreductive nephrectomy immunotherapy era, I think if you go to the trial of these all IOTK, 80% patient had a cytoreductive at the time of starting therapy. From that point of view, we are still not sure whether we can extrapolate the Carmina and certain time for immunotherapy. So till the time the probe trial is ongoing, which will looking the same questions. Till this point of time, we can take a wise decision in the best interest of the patient. And if anyone is doing cytoreductive nephrectomy, they are not wrong, because in 80% patient in the IO plus TKR or IO plus IO, the cytorectomy was done in that study. So I think it's open at this point.
Is there any benefit for cytoreductive in the immunological, because we are reducing the disease burden in a large tumor?
Yes.
Is there any benefit?
So one thing which goes against, so doing a cytoreductive. So what we do that if patient respond well, 1.5 year on a IO plus TKI, then definitely at some point of time, even if that was not done at the beginning, after say 8 month, 10 month, other metastatic site well controlled, then I usually send them for a cytoreductive nephrectomy. So interval cytoreduction will be more used rather than the upfront.
Thank you very much.
Thank you. Thank you, Ginil, for chairing it. And sorry, Paulami, for putting you as the last speaker. Thank you all for being there till the end. And we haven't run that very late. So I think we have done okay. I'm just going to declare the competitive sessions for the paper and video presentation. For the video, it was Dr. Tarun Jindal, if he is there. And for the paper session, it was Manish Singh. And the third one for the poster session, it was Dirush from Chennai. Thank you. You will get a certificate hopefully from the SOGOCON team. Thank you. And thank you very much, Sumantra, for all your efforts. And thanks to the organizing team for putting in a big show. Thank you.